All right, I'm going to go ahead and get started. Thanks to all of you for joining us. This is the SEOW Webinar Series Part 2 of the 3-part series. Yesterday we focused on consumption variables, meaning the prevalence and the use rates of substance use. And today we're going to focus more on the consequences and the impact of substance use in Maine. So yesterday we had plenty of indicators that gave us hope and said we were going in the right direction. Today I can't promise the same thing. We're not going to necessarily have a lot of encouraging variables as the title suggests. These are consequences. So pardon the pun, it's sobering indicators that we're going to take a look at today. So in case you aren't familiar, the SEOW, it stands for the State Epidemiological Outcomes Work Group. My name is Tim Diamede. I've been at this position for about 5 years now. I'm also a prevention data analyst for the SEOW. I'm the coordinator of the SEOW. So just some housekeeping. I tried to put everybody on mute just to limit some background noise. If you do have, we're going to open up for questions after the presentation. If you do have a pressing question, go ahead and put it in the chat box down at the bottom right hand of your screen. And so as far as, oh yeah, I did want to mention, we are recording this, and so I will eventually have this posted to the SEOW dashboard, and you can find that at Maine SEOW. It's at the bottom of the screen, .com. And if you aren't familiar with the dashboard, I encourage you to go there, take a look around, and see what you think, and feedback is always welcome as well. So for today's agenda, for the part 2, we're going to briefly go over the purpose of the SEOW. I always do that just kind of for people that might not be as familiar with it, just give you some major objectives of the work group. Then we're going to go over the actual presentation of the consequences, and I should have stated this before, but basically these webinars, we put together these webinars as a tool or a resource to help digest some of the information that we put out in our annual reports. We know that some of our profiles are very lengthy, and it can be cumbersome for people to comb through them. So these webinars and fact sheets and briefings, presentations we put out are really to help people digest all that information and take away what we think are the salient findings and give you an overview. So after the presentation, I just want to quickly tell you about some new and updated resources that the SEOW have produced recently and show you where they live, and then we'll open up for questions. So hopefully that sounds good to all of you. So as I mentioned, this is the State Epidemiological Outcomes Work Group. This is a product of that work group. And here are the major objectives of the work group. First of all, it's to promote systematic data-driven decision-making. And second of all, it's to guide effective and efficient use of prevention resources. So one of our main objectives are really to help stakeholders in Maine, help prevention professionals and the public health coalitions in Maine figure out where they need to be focusing their scarce resources, and so helping them make data-driven decisions. And so in the SEOW, we work with a ton of data sources and what I call data gatekeepers from each of those sources, and we work with them to really figure out what the most trustworthy and reliable and valid data and information that we should be presenting. And so just to be consistent and that's really some of our major goals there. And of course, the third objective there, obviously we're here to identify and track substance abuse trends, and we kind of parse them out by, you know, the consumption side, with the prevalence, the use rates that we focused on yesterday's webinar, and then we look at the consequences and the impact that substance use has. And then we also look at contributing factors, so some of the perceptions of harm and cultural norms and the potential for diversion, some of those indicators. And tomorrow we'll actually have the third part, and that'll focus more on the contributing factors. And lastly, this is a really important objective that I feel is worth stating, but I haven't always presented it here, but SEOW is here to serve as a clearinghouse of information. There's a ton of information out there, and through all these resources that we produce, it's really to help you guys digest all that information and to work, again, with those data gatekeepers on figuring out what the best way to present this information would be. And we're here to facilitate a conversation around data. So here we're going to start off with substance-exposed baby notifications. And so on the left side of the screen, we have the number of substance-exposed baby notifications to Child Protective Services regarding infants born exposed to substances. And on the right side, we have the proportion of live births with substance-exposed notifications. So it's the same data, but it's just presented differently here. So we can see that in 2015, there were a little over 1,000 notifications to the Child Protective Services. And that's seen quite a substantial increase since 2011 at 667. And on the right side, we can see that in 2015, 8% of the live births in Maine had some sort of notification linked to them. And so I do want to remind people that these numbers, they are going up, but we also have to remember that hospitals might be getting better at reporting this data as well. So increased numbers, yes, they are worth tracking, but I'm almost certain that some facilities they have better education and better ways to track some of this data, and they're getting better at identifying some of these exposed notifications. So here we're looking at the similar indicator here, a proportion of live births, but we're breaking it down by public health district. We're looking at the proportion of live births. And so we can see that Penquist for 2015 had the highest rate at 15%. So about 1 in 5 newborns in Penquist had a substance-exposed notification linked to them. And then the next highest rate was observed in Down East, 10%, so about 1 in 10. And Aroostook and Central both had 9%. And the lowest rate was actually observed in Cumberland at 4%, as well as York had 4% as well. So, excuse me, we're going to shift to some the Maine Drug Enforcement Agency data. We've got a lot of great data from the Maine DEA over the years, thanks to Roy McKinney, the director of the DEA, and his team over there. And I do want to mention that the DEA really focuses on trafficking and sales and manufacturing and intent to sell, and less on possession of drugs. So here we are, we have the number of MDEA drug trafficking investigations by drug type. And we can see that the trafficking investigations related to heroin have actually more than doubled from 2013 to 2015. And that's represented in that blue line, the dark blue line. And as we see the investigations related to heroin increase, we can see the investigations related to other opiates, including synthetic opiates and some of those prescription opiates, those have been steadily decreasing. So we're seeing that shift there. And definitely worth noting is that trafficking investigations related to cocaine also observed a notable increase from 2014 to 2015. So from 151 to 208. So about a 50 increase there, about 30%, I should say. And so this slide isn't looking at MDEA. It's looking at Uniform Crime Report data. And this is great data that I get from the Department of Public Safety from an analyst, Jessica Cummings over there. And this looks at drug offenses involving opium or cocaine and their derivatives. So unlike the Maine DEA, this is all law enforcement data. And this is looking at sales and manufacturing data as well as possession data. And this is looking at a rate per 10,000 residents. So here we can see that the highest rate was observed in Cumberland at 14.5. And that was followed by York at 12.3. And some of the lowest rates were observed in Aroostook at 2.5, as well as in Down East and Penquist around 5 and 6. And so those were arrests or offenses involving opium or cocaine and derivatives. And this one, opium is really talking about heroin and the derivatives of heroin, and it also combines cocaine in this indicator. So this doesn't include some of those pharmaceutical synthetic opioids. Okay, so here we're back at the DEA data here, and this time we're looking at manufacturing investigations related to methamphetamine. And the story here is that basically they've tripled, more than tripled from 2013 to 2015, going from about 27 investigations in 2013 up to 85 investigations in 2015. So these are manufacturing investigations. These are labs, basically. And the labs in Maine are for the most part, what I'm told, because I do serve on the methamphetamine task force, what I'm told is that these are more of kind of backpack labs or labs just for personal use. They're not labs that are generating a whole lot of methamphetamine. They're not the labs that you'd see down south or on shows like Breaking Bad. Okay, let's shift gears here and look at some of the great data we have from the emergency medical service responses. So these are EMS responses. We get this data from the Department of Public Safety, the EMS. John Powers really helps me out with this data. He serves on the SEOW. So this is looking at the number of overdose EMS responses, so like ambulance responses by type of overdose. So drug and medication is all kind of combined there, and alcohol is all ethanol and alcohol, those types of overdose responses. So basically we've seen a gradual increase in both drug and medication overdoses as well as those related to alcohol. So here's that same indicator, but this is broken down by age group. So we're looking at the rate per 1,000 residents by age group. And so the pink bars represent overdose responses related to drug and medication, and the blue bars represent those related to alcohol. So for drug and medication, we can see that the highest rate was observed among the 26 to 35-year-old population. And that was pretty closely followed by the younger adult population, the 18 to 25-year-olds. And as for the alcohol was, those overdoses were highest among the 18 to 25-year-olds, and then next highest among the 46 to 55-year-olds. So here we're just taking those overdose responses, the EMS overdose responses that are related to drug and or medication, and we're parsing them out by a sub-state level, so in this case a public health district level. A lot of the data, much of the data that we break down on our region will be on a public health district level. It will give us reliable results and kind of be sufficient enough for a lot of the stakeholders and grantees of major grants for outcome measures. So we can see here that the highest rate for drug or medication overdoses was observed in Cumberland at 33.6 responses per 10,000 residents. And that was followed by York and Penquist. And the lowest rate was actually observed in Aroostook at 13.4 and down east and mid-coast around 16. And now we're sticking with that EMS data. We do rely quite heavily on this EMS data. We do think it's a good indication. They're the first responders. So here we're looking at, this time, naloxone administrations given out by the EMS responders. And this is looking at the number of administrations as well as the unique individuals. So the red dotted line represents the total number of administrations, and that baby blue line, that's unique individuals. So we can see that from 2013 to 2015, the number of naloxone administrations given by EMS responders more than doubled and went from 705 to nearly 1,600. And we can see that the unique individuals also doubled, well, nearly doubled, from 552 to 1,028 in 2015. And although not explicitly shown here, rates were found to be highest among males 25 to 34 years old. So we do have a ton of data out there, and I don't include everything in these presentations, so I do encourage you to check out some of the resources and reports on the dashboard. So here's the naloxone administrations, but broken up by regional level, public health district level. And this is looking at 2014 and 2015 data. So looking at just 2015 data, we can see that some of the highest rates were observed in York at 11, Cumberland at about 11. This is administrations per 10,000 residents. And then also Central is pretty high up there at 8.4. The lower rate, probably not a surprise to you by now, is in Aroostook at 1.5 administrations per 10,000 residents. So if we look at the trend, 2014 to 2015, we are seeing jumps in Cumberland, York, as well as Central. And we're going to shift gears again here. We're going to go and look at some of the overdose death drug-related data. And this comes from Dr. Marcella Sorg. She's a professor at UMaine and with the Margaret Chase Center at UMaine. And she does a lot of the analysis for the Office of Chief Medical Examiner. We get great data from her. So that light blue line up top of the graph, that shows the total number of drug-related overdose deaths. It's both looking at the illicit and or pharmaceutical drugs. And so we can see a steady increase for the past several years. In 2015, we had 272. The story here is that we can see the red dotted line representing illicit drugs, that's been increasing pretty steadily since 2011, from 20 in 2011 to 163 in 2015, and that surpassed pharmaceutical opioids in 2015. And if we just look at pharmaceutical opioids, that's represented by the darker blue line. We can see that's been pretty stagnant, or has remained relatively unchanged, I should say, for the past several years. And the caveat here is that deaths involving pharmaceuticals and illicit drugs aren't necessarily mutually exclusive. You could have an overdose death, and they could involve both an illicit drug as well as a pharmaceutical drug. All right, we're going to just quickly look at some of these drug overdose deaths, but on a national lens here. And basically, the redder the state, the higher the prevalence is for drug-related overdose deaths. Maine is somewhere between, I think, 16.1 to 18.5 drug-related overdose deaths per 100,000, based on the key here. And we can see that some of the dark red spots include New Hampshire, our neighboring states, New Hampshire, Massachusetts, Rhode Island, and then, others like Pennsylvania, West Virginia, Kentucky, and then some on the west like New Mexico and Utah and Wyoming. Now this map is continuing to look at overdose deaths, but it's looking at a significant change from 2013 to 2014. So those states that are highlighted in red had a statistically significant change. And Maine has been highlighted because we've had a significant change. So Maine, as well as New Hampshire, Massachusetts, and again, some of those higher prevalence states out there like Pennsylvania, New Mexico, have also seen that change. So we're going to go back to state level data here. And this is sticking with the data from Dr. Sorg and the OCME. And this is the percent of drug deaths involving specific drug types. So this is the proportion of those overdose deaths related to drugs. And we can see that in 2015, about 2 in 5 overdose deaths were related to heroin or morphine. That's represented in the red dotted line there. So about 40%. And then, and worth noting is that that proportion is increased from 5% in 2011 all the way up to 40% in 2015. And between 2013 and 2015, fentanyl, so non-pharmaceutical fentanyl, has also seen a steady increase, and it's kind of paralleled with that heroin and morphine increase from 5% in 2013 up to 32%. And so the other drugs depicted here, we can see let's not forget about the benzodiazepines. We can see that in 2015, 28% of drug-related overdose were related to the benzos and tranquilizers. But the benzodiazepines have seen a decrease in the past couple of years. And we can also see a kind of a steady overall decrease with drug-related overdose deaths involving oxycodone, pictured in the darker blue line there, going from 28% in 2012 all the way down to 14% in 2015. So here we're going to look at the same data, but we're looking at drug-related deaths per 100,000 by public health districts. So the highest rates were observed in Cumberland at 20.4 and Central at 19.6. So both those public health districts had around 20 drug-related overdose deaths per 100,000. And the lowest rate was observed in Aroostook at 10.6. And before I move on to, I'm going to move on to treatment after this, I just wanted to quickly show you guys some great data that we get from the Maine Department of Transportation, the Bureau of Highway Safety, Dwayne Burnell and his team over there, and Jessica Bozine. Basically, what this is saying is in 2015, there were a total of 165 crash fatalities. And out of that 165 crash fatalities, 48 of them were involved impaired driving, so alcohol or drugs. So basically, nearly 1 in 3 of all those crash fatalities involved alcohol and or drugs. I just wanted to briefly cover a few treatment slides. And I did want to give a shout out to Joanna Buzzle. She's worked with me many times of data requests, trying to figure out what the most reliable and consistent data to present here. And WITS, that stands for the Web Infrastructure Treatment System, I believe. And so here we're looking at primary treatment admissions. So the primary reason somebody went in for treatment. People can go in for a primary reason, a secondary reason, or even a third reason, a tertiary reason. So here we can see that a little more than 1 in 3 substance use treatment admissions, primary admissions, listed alcohol as the reason for treatment in 2015. And that was followed by heroin / morphine at 27%. And then that was followed by synthetic opiates at 21%, and then marijuana at 7%. So if we look at the same data indicator, but we look at it trending, we can see that alcohol has kind of held its reign steady at the top there at around a third of primary admissions. And so it has decreased slightly from 2011 from 39% to 35% in 2015. But the story here is, again, that shift. We can see that the pink dotted lines, those represent the admissions related to heroin. And as those have steadily increased in proportion from 8% in 2011 to all the way up to 27% in 2015, we've seen a steady decline in the admissions related to synthetic opiates. So synthetic opiates went from about a third of primary admissions to about a fifth of primary admissions in 2015, so from 2012 to 2015. Now, these are treatment admissions among clients who stated they were pregnant at the time of admission. So here we can see that shift again as the primary treatment admissions of those who are pregnant, the proportion of synthetic opiates went from 60%, so 6 out of 10 in 2012, down to 33%, so just about 1 in 3. And as that steadily declined, we are seeing that rise in primary admissions related to heroin from 8% in 2012 to nearly 2/5, 40% there in 2015. Now, worth noting here is that if you add up all the drugs that either are opioids or opiate related, you're looking at more than 8 out of 10 admissions for those who are pregnant are related to an opioid or derivative thereof. And the last couple slides here are broken down by public health district. Here we have primary admissions related to synthetic opiates per 100,000. And we can see that the highest rates were observed in Down East and Mid-Coast at around 245, 250 per 100,000. And those are followed by Central and Western, around 200. And the lowest rates were actually observed in York at 82 and Cumberland at 111. But if we go ahead and look at admissions related to heroin, we can see that rates were highest in Down East. So Down East had some of the higher rates in not only synthetic opiates, but also heroin. And I should note that there's a mistake on the title here. This is 2015 data. It's not 2011 through 2015. It's only 2015. This is a snapshot. And so the difference here is that we're seeing highest rates in York and Cumberland, whereas in the previous slide they had some of the lowest rates from synthetic opiates. So we're seeing that shift again. And then for as far as the lowest rate, that was observed in Aroostook at 24.8. So that concludes the actual data I'm going to present. I'm just going to do a quick summary, show you some where you can find additional resources, and then we'll open up for questions if there are any. So basically, as you heard me say, recently we've seen the impact that arising from synthetic opiates. That's slowly declined as those related to heroin and other non-pharmaceutical opioids like fentanyl. They've definitely been on the rise. And this shift to more potent and more volatile and more dangerous drugs has definitely had a big impact on overdoses, crime, health, and safety in Maine. Some of the emergent drugs like methamphetamine, cocaine, and other potentially addictive drugs like benzodiazepines, they've definitely been having a progressively negative impact in Maine. And let's not forget about some of those alcohol-related morbidity and mortality indicators, especially the crash fatalities, where all crashes, out of all the crashes, about a third are responsible or directly related to impaired driving. And so I just wanted to turn your attention to a few resources that we're always proud to put out each year. So this is from July and August of this year. We have the state profiles, an annual report we update. We try to make it better each year with the help of the SEOW work group. And you can find that in the additional resources section at the data dashboard at maineseow.com. We also put out profiles on 8 of the public health districts to really help the communities figure out, again, how to use the most efficient use of their resources and how to get outcomes and measures. And then we recently put out some fact sheets on the left side of the screen. I'm highlighting the consequence fact sheet that I put out there recently. We also have a fact sheet on consumption as well as contributing factors. So I definitely encourage you guys to take a look at this, print them out, share them if you feel they might help in the next meeting. This is just like a screenshot of the data dashboard. This is what you'd see on the home page. There's a little carousel at the top there that will flip through some of the newest products. The data dashboard is a place you can go for an interactive kind of web data query kind of thing, where you can drill down to public health district for some of our indicators, drill down to gender or age group. That's always being updated or continually changing, and we're always trying to make it better. So please take a look at it and provide us feedback if you have any. And there's a data sources section. So like I'm always talking about these data sources, but there's more succinct descriptions of the data sources, and there's contact information there as well. And of course, there's the additional resources section where we kind of use that as the clearinghouse and put our newest products there. And also we like to highlight other products around the states and other tools around the state as well as the nation that we feel would be helpful to prevention professionals and substance use professionals around the state. So if you have some links that you'd like to see highlighted in additional resources, let me know and I can definitely post them there. And just one reminder, tomorrow is our part 3 of the series, and we will focus on contributing factors. And you can use the same link that you used today to log in. So with that said, I'll go ahead and we'll open up for questions. You can either type in a question or you could unmute yourself by pressing #6. And if #6 doesn't work, please just go ahead and type in your question. All right, I'm going to be respectful of everybody's time. So this webinar is recorded. I'm going to go ahead and wrap up. I will post this to the dashboard as soon as I have approval. It'll be within the additional resource section, and I'll post the recording as well as the PDF of the presentation itself. So if you ever need me, please email me. I'll get right back to you. And feedback is always welcome. So thanks again for joining. Have a great day.